Welcome to this lecture about obstetric Doppler. In this lecture, I will discuss a brief review of Doppler principles. Uterine artery Doppler, umbilical artery Doppler, middle cerebral artery Doppler, and finally ductus venosus Doppler. Ultrasound beams are emitted from a transducer at frequency. When it hits a structure that moves, they are backscattered and Doppler shift arrives to the transducer. The information is analyzed, and it is represented as a waveform. The arterial waveform is characterized by systole and diastole. If the blood flow direction towards the transducer, the waveform is represented above the baseline. If the blood flow direction away from the transducer, the waveform is represented below the baseline. On the y-axis, as you can see on this image, there is the velocity in centimeter per second. It is not always easy to get an angle zero between the ultrasound beam and direction of blood flow. Therefore, the velocity can't be accurately measured in all of the cases. This is the reason why we often use angle-independent Doppler indices to analyze the waveform. If the angle between the ultrasound beam and direction of blood flow is zero, the velocity value reported on y-axis reflects the real velocity of the blood flow. The most useful Doppler indices are SD ratio, resistive index, and pulsatility index. Pulsatility index gives the maximum of hemodynamic information. These indices are independent of the angle, so the values do not change significantly when the angle changes. Look at these two waveforms. They were obtained from the same fetus from umbilical artery, but with different angles between the ultrasound beam and direction of blood flow. If you look at the peak systolic velocity, you can see the peak systolic velocity of the right waveform is about 41 centimeters per second, with the angle about 40 degrees. On the left waveform, the peak systolic velocity is about 27 centimeters per second, with the angle is 0 degrees. Therefore, there is a change in the velocity. But if you look at the Doppler indices, resistive index, pulsatility index, and SD ratio, they are relatively the same in both sides because these Doppler indices are angle independent. Okay, let's start with the uterine artery. The maternal side of the fetoplacental circulation is represented by the uterine artery. The uterine artery is a branch of the internal iliac artery. It enters the myometrium at the junction between the uterine corpus and the cervix. Doppler ultrasound examination of the uterine artery is used in the first trimester to screen for early onset preeclampsia. In the second and third trimesters, Doppler ultrasound of the uterine artery is used in the evaluation of suspected intrauterine growth restriction. Uterine artery Doppler can be used to help distinguish placental causes of growth restriction from other causes of growth restriction. Typically, this screening test is done at 20 weeks of gestation, and if abnormal, it is repeated at 24 weeks of gestation. How to do uterine artery Doppler examination? There are two approaches: transabdominal and transvaginal approach. On transabdominal approach, first identify the external iliac vessels. The uterine artery is seen crossing the external iliac vessels anteriorly, as you can see on this image. The Doppler sample volume is placed about 1 centimeter downstream from the crossover point. Measure the right and left pulsatility index and calculate the mean value. The uterine artery waveforms are displayed here on these two cineclips. As you can see here, these two waveforms are different. The one on the right side of the screen was obtained during the first trimester, while the other one was obtained during the late second trimester. You will know the difference between the two in the next slides. In non-pregnant uterus, the waveform of the uterine arteries is high resistive, with low diastolic flow and early diastolic notching. The resistance to flow in the uterine arteries decreases with advancing gestation in normal pregnancies, reflecting the trophoblastic invasion of the spiral arteries. So, the uterine artery waveform changes from relatively high resistance in the non-pregnant state to a low resistance waveform in pregnancy, with continuous forward flow throughout diastole, as you can see on these images. This process is complete by about 18 weeks of gestation. In pregnancies with impaired placentation, high uterine vascular resistance will persist after this time. Notching is a common feature of the uterine artery Doppler waveform. It is defined as a reduction in forward flow at the start of diastole. It is present normally in non-pregnant uterus and in the first trimester of pregnancy. It is thought to represent abnormal uteroplacental flow. Bilateral persistence notching after 24 weeks of gestation is abnormal. Diastolic notch has been associated with adverse outcomes, including fetal growth restriction, maternal preeclampsia, and increased risk of preterm labor. The uterine artery pulsatility index is a favoring measurement of vascular impedance, because the pulsatility index indirectly includes the presence or absence of early diastolic notch. A normal pulsatility index should be below the 95th percentile for gestational age. An abnormal waveform is characterized by a high pulsatility index above 95th percentile for gestational age. Persistence of bilateral diastolic notch beyond the 24 weeks of gestation is also abnormal. Therefore, uterine artery Doppler can be used to help predict preeclampsia or fetal growth restriction. In the fetus, the umbilical arteries arise from the internal iliac arteries and are responsible for carrying deoxygenated fetal blood to the placenta. Oxygenated blood returns from the placenta to the right atrium by way of the umbilical vein. In clinical practice, Doppler ultrasound of the umbilical artery is not performed until 24 weeks of gestation. However, in the twin-twin transfusion syndrome, Doppler ultrasound of the umbilical artery is performed whenever the diagnosis is suspected, regardless of gestational age. Doppler study of the umbilical arteries is used to manage fetal growth restriction and to stage the twin-twin transfusion syndrome. How to perform umbilical artery Doppler. The International Society of Ultrasound in Obstetric and Gynecology guidelines recommended sampling umbilical arteries in free-floating loops of umbilical cord in singleton. The fetus should be at rest and not breathing, because movement and breathing cause variations in the spectral waveform. The angle of insonation is not crucial, because all Doppler measurements used are angle independent. However, an angle close to 0 degree results in the best Doppler shift and best waveform. The resistance within the umbilical arteries, which is recorded as the pulsatility index, reflects the resistance to flow within the placenta. In a normal functioning placenta, the resistance to blood flow should steadily decrease throughout the pregnancy in response to ongoing development of the placental bed. The resistance to flow within the vessels in the placenta is normally low enough that even in diastole there is forward blood flow. As you can see in these images, there is gradual decrease in the placental resistance with advancing gestation. This is manifested by gradual increase in the diastolic flow. In normal pregnancy, the diastolic flow of the umbilical arteries cannot be detected in the first 10 weeks of gestation due to incomplete villus maturation. It can be detected by about 15 weeks of gestation with the progression of pregnancy. The pulsatility index of the umbilical artery Doppler reflects the resistance to flow within the placenta. The pulsatility index is measured and compared to the gestational age on the charts. A normal pulsatility index of the umbilical arteries should be below the 95th percentile for gestational age.